Hey, hello everybody. I'd like to welcome you to the introductory talk that I'm giving today. I am Chris Paulson. I'm one of the hematologists at Cancer Care Manitoba and the University of Manitoba in Winnipeg, Manitoba. I am a stem cell transplant doc and I treat acute leukemia. I was asked today to give a very basic introduction to transplants. I think it's good though to start off with some definitions just so we're all on the same page as to what I'm talking about when I say transplant. Unfortunately, as in medicine, as in many cases of medicine, we have many names for the same process. And so transplant you may hear called a few different things. Probably the most accurate way to talk about what we do would be hematopoietic stem cell transplant. So we're transplanting into the recipient hematopoietic stem cells, the very most immature blood cells, with the hopes of providing a new blood-making system. We do usually drop that first word, so you won't probably hear that full phrase all that often. And usually when we talk about transplant, we talk about stem cell transplant. Really, at least as of now in 2021, there aren't really any other types of stem cells that are transplanted. So if someone, especially in the context of treating a blood cancer or blood disorder, talks about stem cell transplant, they're referring to hematopoietic stem cell transplant. You may also hear it called a bone marrow transplant. Bone marrow transplant is a little bit of an older term. If it's used now, specifically by someone on the transplant team, it specifically refers to transplants where we take stem cells directly from the bone marrow. But you know, in the lay media, you may hear this described as a somewhat inaccurate way to refer to other types of transplant as well. So bone marrow transplant is maybe less accurate, and in fact, in adults at least, very few of our transplants are done directly with stem cells from the bone marrow. We can further divide it into two types of transplant that we commonly do: autologous stem cell transplant, which is where we take stem cells directly from the donor and give them back to themselves. So your patients donate stem cells back to themselves, or an allergenic transplant where the donor is really anybody else other than the recipient. It's not entirely obvious as to why you would want to do an autologous transplant. You know, what's the benefit of taking stem cells out only to give them back again later? This is how I usually explain it to patients when I see them in clinic. We know that chemotherapy kills cancer cells. We know that the bigger doses of chemotherapy we use, the more cancer cells we can kill. So therefore, at least in that one important way, the bigger the dose, the better. However, with bigger doses of chemotherapy, you get more side effects. Some side effects of chemotherapy are hard on transplant patients, things like nausea, tiredness, or hair loss, but are not life-threatening. Other side effects of cancer treatment, though, are life-threatening, and the most important life-threatening side effect of chemotherapy is usually low blood count, specifically a low white blood cell count, specifically a low neutrophil count, the type of white blood cells that's important in responding immediately to infection. So autologous transplant is really a shortcut around this one big important side effect of chemotherapy, low blood counts. It allows us to give a bigger than usual dose of chemotherapy in a safer way. How we do this is actually pretty simple. We collect stem cells from the patient prior to transplant. We take the stem cells, we put them in our freezer in the cancer center or in the hospital. A few weeks later, we admit the patient, usually to hospital, although there are some places in Canada that will do this from the outpatient clinic, but we always give the patient very, very high doses of chemotherapy, again, with the aim at killing as many cancer cells as we can. After we give the chemotherapy, we allow a day or two for the chemotherapy to be washed out and cleared by the liver and the kidneys. We take the stem cells out of the freezer, we thaw them, and we give them back to the patient, usually through an intravenous in the arm. And instead of having low blood counts for months or years, the blood counts recover a couple weeks later. So autologous transplant is a safer way to deliver higher than normal doses of chemotherapy. So it's a shortcut around that one big side effect of a transplant, of chemotherapy, the low blood counts. And I talked about this already. Again, it's a few-step process, but it's all pretty simple. This is something we do fairly routinely at most big transplant centers in Canada. The patient donates stem cells, take the stem cells, put them in the freezer, admit the patient to the transplant ward, in most cases, give the patient high-dose chemotherapy with the aim at killing as many cancer cells as we can. And then after the chemotherapy is given, we take the stem cells out of the freezer to thaw them in our center, and most centers it's just thawed in a little hot water bath. And then we give the patient back the stem cells through the intravenous. Of course, the stem cells weren't exposed to the chemotherapy because they were safely in our freezer when the chemotherapy was given. And the stem cells are smart little guys. They make their way to the bone marrow and start making new blood cells. It takes them 10 to 20 days usually to settle in. We have a couple ways of getting stem cells out of the patient. We can take the patient to the operating room, put them to sleep, and draw the stem cells out directly from the bone marrow. This is a minor surgical procedure, usually goes pretty smoothly. This was the original way to collect stem cells, and this is how transplant was done for many decades before they realized there was an easier, safer way to collect stem cells, and that's what we call peripheral blood stem cell collection. And this is done in the outpatient clinic. The patient is given a few days in a row of a growth hormone, something called GCSF or Graft. This growth hormone causes the stem cells inside the bone marrow to increase in number, and eventually they spill out of the bone marrow into the bloodstream. We then filter the blood and collect the stem cells in a little bag. So this is obviously much more pleasant experience than going to the operating room and having large amounts of blood taken up from the bone marrow. And this is how almost all autologous transplants are done. Now it would be incredibly rare to have a bone marrow collection done for an autologous transplant. And indeed, at least in adults, many allogeneic transplants are done also using this peripheral blood stem cell collection. To do an auto transplant, an autologous transplant, you have to have a few key conditions met before we know it makes sense to go ahead. We have to know that high-dose chemotherapy must be much more effective than standard dose chemotherapy, and this is the case in most, but not all types of blood cancer. We have to know that the side effects of high-dose chemotherapy are mostly related to the blood-making system. So if giving high-dose chemotherapy results in a lot of toxicity to the liver or the gut or the heart or the lungs, then obviously giving them peripheral blood stem cells isn't going to help that all that much. And so the first and most important side effect of the chemotherapy we use must be low blood counts. And this is the case often in blood cancers. Next, the patient must be well enough to tolerate high-dose chemotherapy. I mentioned that it takes a week or two for the blood counts to recover following transplant, and during that time, patients are at significant risk for infection, and they have to be well enough to tolerate that few-week period with low blood counts before the blood counts recover. And lastly, for complicated reasons, transplant usually works well, or works better, pardon me, to sort of mop up the last little bit of cancer that's left, rather than as the first treatment. So we will often want patients to have their lymphoma or myeloma at least mostly gone before we'll consider a transplant. Allogeneic transplant is a completely different entity. As allogeneic transplant is a transplant where we take stem cells from a donor that is anyone other than the patient. It actually follows a similar process. So we still collect stem cells. This time we collect them from a donor who is anybody other than the patient, either they're a family member or a volunteer unrelated donor. Again, just like before, we take the patient and admit them to hospital, usually give them high doses of chemotherapy. We then take the stem cells from the donor and infuse them in the patient's arm just through the intravenous. And again, we still see blood counts recover a few weeks later. So the process is fairly similar to an allogeneic transplant, except the donor is different. However, this fact that the donor is different than the patient has very big implications. And this means that the experience of a patient undergoing allogeneic transplant is very different than the experience of a patient undergoing autologous transplant. The recipient, the patient, now has a completely brand new immune system, a completely brand new blood making system, and this has big implications. There are a few reasons as to why you may want this. Firstly, just like autologous transplant, allogeneic transplant is a safer way to deliver high-dose chemotherapy. However, you get a few extra benefits to allogeneic transplant that also come with some consequences. Allogeneic transplant allows us to replace a broken or dysfunctional blood-making system. So for patients with low blood counts associated with something like aplastic anemia, or patients with sickle cell disease or thalassemia, this is the main reason why we would do a transplant. We would give them a blood-making system that functions normally, that of the donor. Similarly, for patients with a broken or dysfunctional immune systems, patients, for example, with congenital immunodeficiency syndromes, allogeneic transplant again offers the potential to replace that broken immune system with a totally functional, brand new immune system, that of the donor. And so for some patients, allogeneic transplant is really their only option, or at least their only transplant option. And in many of these cases, it's the only curative option. The last reason, number 4, is important for many patients with blood cancers, and autologous transplant, again, is the safer way to give high-dose chemotherapy. Allogeneic transplant, you get that benefit, but you also get what we call a graft versus tumor effect. So the brand new immune system hopefully will start attacking and killing cancer cells. And this is an important reason as to why we do transplant, why we do allogeneic transplant. In many patients with cancer, if you only want to deliver high-dose chemotherapy, autologous transplant is much safer. However, you don't get that graft versus tumor effect, and that allows us to do transplant for patients with, for example, acute leukemia, for which the major type of transplant done is allogeneic transplant, really for that aim to foster this graft versus tumor effect. Obviously, to do a transplant in someone other than the patient, you need a donor. This is fortunately usually easily manageable, at least in 2021. This was not always the case, but now most patients who need a transplant will have a viable donor. We use something called Hla typing to help us decide what donor options are available. Hla is a set of markers that is expressed on the surface of some blood cells in the body. Hla you can think of as like a fingerprint that's unique to an individually. And that fingerprint tells the immune system what is friendly and what is not. And we use this system to match donors and recipients. And we look at specifically 8 markers that should be matched between a donor and a recipient to help us decide what's a safe donor and what's not a safe donor. There are 4 commonly used donor options. The original transplants done in the 80s and 90s were done with matched sibling donors. So these are fully matched brothers and sisters, matched at all 8 of those HLA markers that I talked about in the last slide. And just from the way genetics works, we know that 1 out of every 4 siblings will be a full match. So if you happen to have a big family, you might get lucky and have a fully matched available sibling donor. And this, in most cases, is still the preferred donor option. In the 2000s, they realized that through Hla typing, they could identify unrelated donors that were also matched. And now we're to the point where there are between 15 and 20 million people worldwide who sign up to be volunteer stem cell donors. The odds of an individual patient matching to a donor in the registry is small, but because there are 15 to 20 million people worldwide, many patients will have a match on one of these registries. It is actually much more likely to have a match in some ethnicities. People of Caucasian descent have a higher likelihood of having a matched unrelated donor than people of other ethnic backgrounds. This leads to a significant gap, particularly in disadvantaged populations. And to a large extent, this gap has been managed through what we call alternate donor transplantation. So up until 10 years ago, haploidentical transplants were rarely done in Canada, or even indeed worldwide. Haploidentical related donors are half-matched family members. We know now that through adding in 1 extra medication after transplant, something we call post-transplant cyclophosphamide, we can safely do haploidentical transplants with outcomes that are very similar to those in matched sibling donors and matched unrelated donors. Haploidentical transplants are almost always available, so all biologic children and parents of a potential transplant recipient will be haploidentical matches. and then half of all siblings will also be a match. So haploidentical donor transplant is a option for patients now, in particular, that don't have a viable sibling donor and unrelated donor. Lastly, umbilical cord blood is blood that is normally discarded after birth in the umbilical cord, but it is actually a rich source of stem cells. It is frequently, though, small volume, and that means that it's really an option mostly for children, less so in adults. But it is an option, and it's commonly done in pediatrics in Canada. So I mentioned earlier that one of the consequences, and sometimes one of the goals of transplant, is to replace the donor immune system with that of, replace the recipient immune system with that of the donor immune system. So patients who undergo transplant, allogeneic transplant, have a brand new immune system. And this has a couple very important consequences. Firstly, recipients of allogeneic transplant are much more immunocompromised than recipients of autologous transplants. They essentially have a brand new immune system starting from scratch on day one, and this results in much higher rates of infection. So autologous transplant is much safer than allogeneic transplant, and that is one of the bigger reasons why. Also, this leads to a unique disease that we see only in allogeneic transplant, something we call graft versus host disease. So the recipient has a brand new immune system, that of their donor, and donor immune cells can recognize parts of the patient and attack them. So say, for example, I was a donor for one of you that needed a transplant. It would be my white blood cells floating around through your veins, and my white blood cells might get confused when they see your skin or your liver and start to attack it, thinking that it was a bad infection. We see graft versus host disease fairly commonly. Acute graft versus host disease presents within the first few months following transplant. Common symptoms of acute graft versus host disease are things like skin rash or diarrhea, as well as changes in their liver blood work. We'll also see chronic graft versus host disease, which usually happens 3 months or later after transplant. Chronic graft versus host disease has many more different presentations than acute. This is a common way in which patients with chronic graft versus host disease present, so with symptoms that are very similar to a disease called scleroderma. They present with thickened, tightened, hidebound skin, which can lead to decreased range of motion about their joints and skin ulcers even. So again, the two types of stem cell transplant that we do are either autologous or allogeneic. The major difference between the two of them is that in autologous, the donor is the patient, whereas in allogeneic, it's anybody else, typically either a relative or a volunteer unrelated donor. Again, in autologous, the reason to do a transplant is to safely deliver higher than normal doses of chemotherapy. In allogeneic transplant, the reason for doing this, again, varies. It's sometimes to deliver a safer dose of safer than usual dose of chemotherapy. Sometimes it's to give them a brand new immune system, a brand new blood making system, or sometimes it's to develop this graft versus malignancy effect, which I mentioned earlier. It's a process by which the new immune system attacks and kills their cancer cells, which is incredibly beneficial, specifically in patients with acute leukemia. Graft versus host disease is very common in patients undergoing allogeneic transplant, but it's practically speaking either incredibly rare or impossible in allogeneic or autologous transplant, depending on who you ask. The immunocompromise in allogeneic transplant is much higher due to infections and graft versus host disease, which makes it much riskier to the patient. You may wonder, which patients should get a transplant. This is a very complicated discussion, and it depends a lot on which disease you have. In general terms, of course, knowing that there are some overlap and some exceptions, we talk about allogeneic transplant for patients with acute leukemia, both acute myeloid leukemia and acute lymphoblastic leukemia. Many patients with high-risk acute myeloid leukemia, for example, undergo a transplant, and that is the most common reason for an allogeneic transplant in Canada and worldwide. In diseases like myelodysplasia or myeloproliferative diseases like myelofibrosis, you have an underlying stem cell defect, a broken stem cell in the bone marrow, and so an allogeneic transplant is, for these diseases, the only curative option. And lastly, For patients with immunodeficiency or hemoglobinopathy, transplant again is the only curative option, at least as of now. That may be changing with gene therapy in the near future. Autologous transplant, most autologous transplants in Canada are done for either aggressive lymphomas or multiple myeloma. The standard therapy for most patients under the age of 70 with multiple myeloma is an autologous transplant. So multiple myeloma is the most common reason for which an autologous transplant is done in Canada in 2021. So to sort of wrap things up here, autologous transplant really is just a safer way to deliver higher than normal doses of chemotherapy. Allergenic transplant, you get that benefit, but you also get a few other benefits. You get a brand new immune system and a brand new living system. You also get a few new side effects, and that's graft versus host disease and increased degree of immunosuppression, increased risk for infection. In general terms, autologous transplants done for lymphoma and myeloma. In general terms, allogeneic transplants done for acute leukemia, MDS, and myelodysplastic syndrome, and myeloproliferative diseases. And as mentioned previously, complications of transplant are vary quite a bit, but are much lower in patients with autologous transplant. The main risks are infection or organ damage from the chemotherapy. Allogeneic transplant, you get that in higher rates, and you also get graft versus host disease. Well, this was a nice introduction to transplant. I know that this is the first of many lectures that we're going to be putting together as part of the BMT101 package, but hopefully this grounds you, and I'm sure you'll learn a lot more about everything I just talked about from many of my colleagues in the next few talks. Thank you.